Erin is a senior fellow, and forgive me for reading because I just met with Erin today, in the Department of Psychiatry and Behavioral Sciences in the medical school here at the University of Washington, and he's also a research associate at Seattle Children's Hospital. He received his doctorate in clinical child psychology from DePaul University in Chicago, Illinois, and he has been involved in many projects examining the implementation, effectiveness, and impact of school-based mental health services. His research is focused on training school-based providers in evidence-based practice, and I know we're all going to enjoy his presentation today. Welcome.
Okay. So this talk is called In Pursuit of Evidence-Based Practice in School Mental Health. And I just want to underscore that because I think relative to a lot of other sort of areas of mental health care and healthcare in general, school-based mental health has a ways to go and a little catching up to do in order to have sort of the evidence base that, although limited in other domains, it has at least it's had more time to become established. So I just want to underscore that because I think we have a ways to go, and I'll be talking a lot about the unique context of schools and how that impacts, at the very least, the transportability or the implementation of, let's say, evidence-based mental health practices from other settings that often get applied in the schools, and to what extent that's appropriate or not as much. So this is just kind of an overview or summary of the points I'm going to make. And we'll kind of walk through these more or less in order. Schools provide more mental health services than all other service sectors combined. And I kind of can't overstate how important this is and how really good schools can be at reducing service and access disparities. Schools represent a unique context in which the applicability of many evidence-based practices or mental health evidence-based practices are untested. Regardless, school-based mental health clinicians still need to come up with some sort of treatment approach and need to integrate research evidence into their practice, again, in the same way that practitioners do in any clinical context. In Seattle school-based health centers, I'm going to be talking about some of the work that we've been doing over the last few years and two methods that we've been pursuing to support service quality and improving service quality through flexible evidence-based practice implementation. And this includes the use of some modular psychotherapy approaches, as well as a focus on standardized assessment and progress monitoring. So jumping into it, this is a story, this is kind of a why school-based mental health. And this is a story that I've told a lot, and I think a lot of people tell. Obviously, most youth who require mental health services don't receive those services. And these gaps are seen most readily among low SES and racial and ethnic minority youth. And schools, there's really some pretty good data, and more data keep coming out to demonstrate that schools are an appropriate and effective way of reducing some of these service access disparities. There's another question of sort of what the content of the services is when kids are actually getting in there, getting into the office or receiving services in some other way. But there's a good amount of data, some of which we've collected, demonstrating that school-based mental health services are an effective way to reduce some of these access disparities. These are some data we collected on youth with symptoms of depression. And you see across these different racial and ethnic groups, there's definite differences, and these are statistically significant differences in specialty mental health service utilization. This is controlling for other predictors of use, including gender and SES, and actually severity of symptoms of depression. But what you don't see is a statistically significant difference in school-based mental health service utilization. I think that this just sort of underscores how important schools can be for reducing some of these disparities. For a lot of these reasons, schools are called the de facto service setting for all youth. There's a lot of reasons for that. Some of it's related to purely practical reasons, some of it related to reduction of stigma for actually needing to go to, say, a specialty mental health clinic to seek services. But school-based mental health ends up accounting for over 70% of all mental health services in the state. That's a lot of mental health services. And we have about 20% of all kids receiving some sort of school-based mental health service annually. So you take, let's say, the average population of Garfield High School. school is, I think, around 1,900 kids, and you take 20% of that, what is that, about 380 kids in that school who are going to receive school-based services in any given year. That's a lot of kids. So I think we're dealing with a very large population of service recipients. So it's important to think very carefully about what sort of services these kids are getting. There's a lot of different models of school-based mental health service delivery. I think, and I'm guilty of this too, many people talk about school-based mental health sort of as this amorphous thing that could mean all sorts of different things. These are 5 different kind of models of school-based service delivery laid out by a really nice report by SAMHSA in 2005 done by Foster and colleagues. And these are certainly not mutually exclusive, and they're overlapping. You can see how they overlap in a lot of different ways. But there's a lot of different, even within these, there's a lot of different service delivery kind of sub-models that you might see. But models include school finance, student support services, so the school districts actually hire staff to provide traditional mental health services. The first one in bold, I've kind of bolded those that, at least to my knowledge, are present to one extent or another here in Seattle. Second one being formal connections with community mental health services. And this is something that is pretty widespread in my experience, and at least certainly in the sort of specific work that I've been doing here in Seattle. This is where there's agreements between schools or school districts and community agencies to provide mental health services, and that might happen either at the agency or within the school. A model of this, and sort of one example, is the school-based health centers or wellness centers that we've done a lot of work with in schools. These are actually staffed by sponsor organizations in the community, but there's actual space in the school for them to provide care. There's also school district mental health units and clinics, in which districts operate their own mental health clinics or multidisciplinary teams. There's classroom-based curricula, and I think that this is sort of maybe at one end of the prevention-intervention spectrum, because these are more prevention-oriented, often violence prevention-oriented, and there's a lot of good programs and good data surrounding a lot of these types of interventions. They might be teacher-delivered, but I think when you're thinking broadly about what school mental health is and what school-based mental health services are, it's important to sort of conceptualize it as this broad spectrum of care, from high-severity kids who really need indicated services to kids who might be at risk or even not particularly at risk, but are receiving sort of in the context of a school-wide or classroom-wide kind of intervention, some kind of service. And then also more comprehensive or multifaceted and integrated approaches where a number of different partners are brought together to provide more of a full spectrum of mental health services. We're doing a small project right now with some school-based wraparound services, kind of a pared-down model of that in middle schools, kind of bring together different kinds of service providers in schools in order to facilitate appropriate referral and linkage and things such as that. So that's sort of the overview of the types of different models that are out there. This figure represents some data, again, from that SAMHSA report that I think are very interesting because it lays out the number of staff across schools. And this survey, I think, had over 83,000 schools represented in it. It's a very large-scale survey, and I think provides really good information about the nature of mental health service delivery. What you'll see is that actually the most common number of staff providing services is 3, but I think in some ways this is actually misleading because this isn't necessarily full-time staff. These are staff who are providing some degree of mental health services, many of them less than half the time. There's a very wide range, in addition to a wide range of models, there's a wide range of types of practitioners. And I'm sure that people here in the audience represent a range of practitioners who either could be or are providing school-based mental health services. That includes dedicated school mental health counselors, school social workers, school nurses, school counselors, kind of like guidance counselors who often end up providing mental health services kind of depending on their training or depending on what else is available. So there's a very broad array of individuals who are doing this kind of work. As far as the services that are provided, these data come from the same survey. You see a lot of assessment, consultation, crisis intervention, referral. Those first 4 right there, very short-term kinds of interventions, assessment-based, maybe a very brief intervention, and then moving on or potentially referring if there's something else. But right after that, you see individual counseling or therapy, case management, and some other things that might be ongoing for a while. All the way down at the end, you see medication management, but I do think it's noteworthy that in about 34% of the schools surveyed, there was some medication management for mental health issues being provided. So, moving into sort of the specific model of school-based mental health service delivery, which I'm most familiar, the school-based health center. This is really an integrated care delivery model in which clinics are actually situated within schools. They operate in nearly 2,000 schools in the U.S. I think about 70% of schools have a school-based health center. They typically provide both primary care and mental health services, as well as often a variety of other kinds of services, including reproductive health and other kinds of care. And these, like many mental health, the school-based mental health services, are a pretty well-substantiated mechanism for increasing service accessibility to the kids who really would be otherwise unlikely to be getting that care. In Seattle, I think we have 15 plus SDHCs, and that's because it's continually growing. There's 15 currently within the general education schools, as well as a few others in a few more alternative settings. They're all managed by Public Health of Seattle County as their program manager, and there's an additional 4 healthcare organizations that serve as the sponsors and are actually staffing these programs. And I'll show them in a minute as well. Obviously, because this is a school-based program, the school district and city are key partners. The school district is actually providing space within the schools for these clinics to exist. So I won't go through all of these, but you'll see the 5 different sponsors up there, as well as the schools that they're responsible for currently, including group health, neighbor care, public health, Seattle County, as I was talking about, Swedish Medical Center, and the Children's Abyss Brown Clinic, each providing for one school. So the model includes a full-time mid-level practitioner at the nurse practitioner or physician's assistant level, as well as a full-time mental health counselor, although there are some people who job share. But for the most part, we're talking about one dedicated mental health counselor, which actually is pretty good. And if you think about school-based mental health services nationally, having a full-time dedicated mental health counselor is nearly phenomenal to be able to be responsible for the care of an entire school. As well as an administrative support staff. At the middle school level, they have a half-time medical provider, and many staff, or many centers also offer these enhanced services, including education, nutrition, some naturopathic medicine. So this is sort of the array of services, both primary care and interventions and strategies that support school success, although I would argue that all of these are intended to support school success. That's sort of the reason why we're in there. That's, I think, what most of us would argue and have argued and will continue to argue is the point of all this. I mean, service provision for its own sake, I think, is a good thing, but it's hard to justify the space and resources and time when you're not looking at an ultimate outcome that's going to be functional, and the most important functional outcome when you're dealing with schools being academic systems, arguably. When thinking about school-based mental health and thinking about evidence-based practice in general, I think this quote really sums up and underscores a lot of the important points. I'm just going to read it. It's important to emphasize that promotion of effective mental health practices in schools involves more than simply trumpeting the selection of evidence-based approaches, most of which are examined for their effectiveness, palatability, durability, affordability, transportability, and sustainability in real-world school or clinic settings. And I think that this just kind of nails it. I mean, in part, by saying many things about it. It's kind of comprehensive in a way. But it really nails the point that we have these evidence-based practices and we have school-based services occurring. Many of the evidence-based practices have been built and tested in settings that aren't schools. Some of them have been in schools, but there's many that have not. And thinking about what evidence-based school-based mental health service provision is requires an understanding of how those things are going to fit together. So that's what I'm going to be talking about a little bit more. First, I want to talk a little bit about the context of school-based mental health. Obviously, there have been a number of people writing about how evidence-based practice developers have kind of paid insufficient attention to the school context. And that school context involves a lot of different things, but some of the ones that I've listed here include a range of presenting problems, symptom severity or level of functioning, treatment engagement or duration, as well as organizational supports and barriers. Now, these are all aspects of service settings anyway, but I would argue that within schools, the variability represented here is probably as broad or broader than a lot of other service settings. So just sort of walking through some of these different aspects of the school context, presenting problems. The most common presenting problems in schools tend to be social, interpersonal, or family problems. And there's certainly a lot of service provision for externalizing or disruptive behavior disorders, and those are pretty common in many school-based mental health settings, and as you might expect, especially among males. The most common diagnoses are often dependent on factors such as age or demographics, referral processes, confidentiality approaches. For instance, we have pretty predictable gender differences in terms of presenting problems, with more internalizing problems experienced by the girls who might be presenting for services, but also these referral processes and whether they're sent there or almost semi-mandated to go and receive some sort of school-based mental health service, or whether it's more of an independent, sometimes confidential process for going and seeking services and seeking care. And when that happens, you tend to see more internalizing problems, fewer externalizing problems, because those are the people who wouldn't necessarily be identified otherwise, but have sort of self-identified for some reason in order to go and receive care. So the most common that we've picked up on in our work with Seattle school-based health centers are interpersonal problems, I've already talked about, as well as depression and anxiety. And lots of that has to do with how the school-based health centers are a pretty voluntary segment, it's a pretty voluntary service provision model. Just looking at a little bit of data breaking it down by gender, we see male and female differences, not so many differences actually on the most common presenting problem area, social or interpersonal issues, but we see gender differences emerge pretty quickly when you start talking about aggression, behavior problems, sort of more of the externalizing end of things, and then adjustment, anxiety, and depression issues, where you see more common among female students. So thinking about those kind of problem type, right? But thinking about symptom severity, I think it's really important to consider the range of severity that we're talking about. Often we make the assumption that if we're talking about kind of mental health and clinical problems, we're talking about the clinical level of severity. And that's not necessarily what we found, especially now that we've been finding in the school-based health centers. This is the results from a relatively small sample, and it is more of a convenient sample. So I want to put a caveat out there, but of the strengths and difficulties questionnaire, which is sort of one of the broad standardized assessment scales to look at a number of different domains of the psychosocial function. And emotional symptoms, behavior difficulties, emotional symptoms being anxiety and depression. Emotional symptoms, behavior difficulties, hyperactivity, across all of these, we're seeing more than 50% are falling into this non-clinical range. Then, we're getting 10+% are experiencing something sort of in the middle, this like moderate level of symptoms. And those who are actually crossing over through this clinical threshold, at least according to this Feeler measure, maybe a quarter, at least within each domain for total difficulties for that particular scale. We see an even smaller number, but I think that that's just a very important thing to think about when we're trying to figure out how well these evidence-based practices that may have been designed for a pretty severe clinical sample are going to apply to kids who are actually getting care. And we see this again. This is relatively recent data we collected, or the school-based counselors and school-based health centers collected in September. Over 180 youth on depression and anxiety. That's the Patient Health Code Questionnaire 9, and that's the MAPS 10 measure of anxiety. Those are some scores up there, so you see a little different distribution. But what we do see across both of these is that the majority of kids fall below that line being moderate symptoms or above. So we're really looking at the majority of these kids are not crossing over into that threshold. So I don't know if I necessarily have a very good solution for all of this. We'll talk about, especially when we get into progress monitoring later on, and talking there. But we're talking about a really wide range of severity and a substantial number of kids who might not fit the traditional clinical bill. Treatment duration varies, in part because of the level of severity, also because this is a setting with a lot of service flexibility. And that's kind of a blessing and a curse. Providers can often, if they happen to miss a kid one day, they can try them again later in the week. But it also makes them very accessible if crises come up, and some kids, some might not seem as severe and get bumped. So I think there's a lot of juggling they need to do in order to really identify how they're going to spend the time. The small number of providers responsible for an entire school really ensures that, because there are these time, practice, and caseload size parameters that these clinicians really need to think about. So because that's the case, intervention often winds up being pretty short term. We're looking at some data where the average number of mental health therapy sessions was about 4.6 per semester, but I'll show you some data later on from some of the work that we've done. The modal number, so sort of the most common number of sessions, is actually even lower than that. It winds up being 3 or so. So if, in part that fits with the level of severity, but it's important to keep in mind. And attendance, of course, attendance at school can be unpredictable in addition to attendance in their actual therapy office. If the, especially based on what we know about how attendance and mental health problems are related. So the most severe kids actually aren't there. And if you're not there, it's hard to get school-based mental health services. Organizational supports, obviously these vary. This is something that gets identified a lot within the implementation science literature, and has really been underscored lately as important to the implementation of evidence-based practices. There's a lot of different aspects of the organization which can be conceptualized in a number of different ways. Is it the school, is it the district, is it the community sponsor? Those are just sort of things to think about when conceptualizing it. We also know that evidence-based practice implementation in schools, there's a nice, some qualitative work done by Langley and colleagues looking at how social networks of practitioners delivering similar interventions facilitated implementation. Administrative support for implementation was also a facilitating factor, as, not surprisingly, was one. So when we're really thinking about evidence-based practice in school mental health, obviously all of the usual caveats related to evidence-based practice certainly apply. Sort of the usual caveats plus. There's a substantial need for flexibility, and that's true for all evidence-based practices, particularly in schools. There's questions about the sort of capacity of existing evidence-based practices or empirically supported treatments to address a full range of problems that kids are coming in with. And I think there's also something that should be underscored in particular. When we're talking about a service setting that increases the accessibility of services for kids who aren't ordinarily receiving them, I think it makes the cultural relevance of particular evidence-based practices that much more important and that much more essential to think about. So the majority of specific interventions, school-based mental health interventions with empirical support, have been for behavioral problems. Many of these are those sort of prevention-oriented, classroom-level interventions that I've been talking about. And there's been some really great work surrounding those that I won't get into right now. But there's also been relatively little research surrounding the impact of school-based mental health interventions on academic outcomes. And in some ways, we're doing a disservice to ourselves and to everyone else, not making those links clear. But we're also not necessarily making those links because those links are hard to make, and because making the connection to academic outcomes often involves a few steps, if you think about it conceptually. So what I'm going to get into now is really a couple of the projects that we've been working on lately, implementing evidence-based practices in Seattle school-based health centers. Since about 2006, our team of researchers, since before I arrived on the scene actually, have had an ongoing training relationship with school-based health centers. And this has been open to providers from all the different school-based health center sites, involves CE credits, and really focused above all else on addressing barriers to implementation and kind of enhancing the fit of the evidence-based practices within the school context. So the recent efforts that I'm going to talk about right now include the flexible implementation of a modular intervention model, and I'll talk a little bit about what I mean by that, with the goal of providing flexible EBP services, and then increasing provider use of standardized assessment and routine progress monitoring. And And at the end, I'll actually walk through some of what we've been doing with them, and hopefully you'll be able to walk away with a few clinical tidbits surrounding that. I want to just lay out a little bit of the common elements and common factors approach, because these are, I think, both important and both sometimes confusing. They mostly common. What do we mean by each one? And that a lot of our work has been driven by a common elements approach, although it's certainly been informed by some of the common factors work that's been going on. Common elements basically mean a generic, a sort of focus on what are the generic elements of treatment, of what's going on in the treatment session that can cut across the treatment protocols. This might be exposure, psychoeducation, cognitive restructuring, things like that, that are common to multiple kinds of evidence-based practices across different types of preventive problems. Common factors having more of a focus on personal and interpersonal components, such as alliance or therapist effects that are common to all interventions and responsible for treatment outcomes. So really, really great paper that's in press right now, I believe, in research on social work practice by Barth and colleagues that lays out both common elements and common factors, specifically as they relate to clinical social work. And I recommend you take a look. So the rationale for our modular psychotherapy pilot, which again is driven largely by kind of a common elements orientation, is that modular psychotherapies are more flexible. Modular psychotherapies that make use of these different practice elements that are common across interventions than traditional manuals. That this flexibility facilitates their dissemination to schools, and that they have the potential to be tailored in order to be maximally effective, to prioritize certain kinds of intervention components in the limited number of sessions available. So what we've done, this is an example of some modular psychotherapy resources that have informed our pilot when we did it, that come from the PracticeWise site that's put together by Bruce Torpedo, who's been sort of a leading force in modular psychotherapy. And just to walk through it really quickly, it has three major components. The first being this website, this PracticeWise website, which is kind of a living, breathing meta-analysis of what has been effective in youth mental health services. And you can enter various characteristics of your individual client or hypothetical client, and also your service setting. Although it's interesting, if you indicate that you want to see what has actual empirical support from schools, it severely limits the actual output that we get, not surprising. The practice elements being these two-page overviews of what the actual content is of a particular element, and kind of a blow-by-blow guide for implementing it, or at least jogging one's memory after you receive some training in it. And then, very importantly, the clinical dashboard, which allows for the tracking over time of both client outcome and practitioner use of these practice elements. So that's just sort of an overview of a way, one way, not the only way certainly, but one way that sort of a common elements approach can be implemented and turned into some resources. In our pilot, which was informed by these practices, we used a subset, just 12 practice elements that corresponded to the most common presenting problems. And I just want to make a point, this is the most common presenting mental health problems. We weren't really using anything that was, let's say, specifically outside of the context of anxiety or depression, tailored for those interpersonal problems that are such a presenting issue among kids in schools. And the counselors tracked their practice element implementation and outcome using the dashboard. So we had a small number of counselors who were with us for the entire year, and they tracked about 66 students, or exactly 66 students, primarily depressed kids, over 487 sessions. And the mean number of sessions was 7.4. We had instructed the counselors to pick kids who were actually likely to come back for at least 3 sessions. And you can see that's exactly what they did. So even though they were picking kids who would come back for 3 or more sessions, they still wound up with a total number of sessions. In 94% of the sessions, students received at least one standardized assessment measure, which is something we really pushed, and something that was actually pretty encouraging. The most common standardized assessment measure corresponds to the presenting problem of depression appropriately. But it was really this success surrounding use of standardized assessment and use of sort of systematically looking at presenting problems that led us to the standardized assessment and progress monitoring focus. Just defining standardized assessment, this is the use of measurement tools with empirical support for their reliability and validity. And our focus, and really the rationale for this is that focusing on incorporating assessment and progress monitoring into school-based practice can increase the ease and accuracy of clinical diagnosis, again, for those kids for whom it would be appropriate. The clinicians, we have a lot of data that as much as we wish our clinical judgment were available, it's not necessarily. And there's a good amount of research to demonstrate that clinicians aren't necessarily able to detect client deterioration, and that there can be ways to sort of augment this. And administering standardized assessment measures and providing the results to clinicians can improve certainly. Some of the work done by Lyon actually kind of grows out of more common factors and common elements of approach. Has actually been some of the most cutting-edge and groundbreaking work when it comes to standardized assessment. So here's just some steps to standardized assessment tools, and I won't walk through them all, but I put them up there to just sort of demonstrate how standardized assessment can break down at lots of different points in the game. You might administer it, you might score it, or you might score it, and not actually make use of it. And what we've really been talking to clinicians about is making use of that information and providing feedback and trying to use that to turn the process of assessment and feedback into one that's much more collaborative and client-centered. Feedback intervention theory is sort of one way we've been conceptualizing this that just says the behavior is regulated by comparisons of feedback to goals, and that feedback in the context of this helps to shape therapist behavior in response to this reliable information source, regardless of the theoretical orientation or intervention approach. And there's data that, independent of those things, progress monitoring and getting reliable information about where your client is associated with improvements in outcome. There's a few different levels of feedback. There's feedback to the client, and then of course there's feedback to the counselor. And a lot of the work is focused on feedback to the counselor or therapist. So feedback to the client also has potential for improving therapy with alliance and contributing to positive treatment effects, and is associated with things like higher rapport and engagement. So what I have up here is sort of shifting slightly from standardized assessment to progress monitoring, which might include standardized assessment tools, again, these that have strong psychometrics and allow kids to be compared to normative data. But thinking about progress monitoring, where you end up being a little less interested in how kids compare to normative data. That's still important, but over time, if you're going to be seeing a kid a number of times and hoping that they're going to improve, what are you interested in? You're interested in how that kid is relative to how they were when they came in. So in the context of that, progress monitoring can involve measures that are a little more idiosyncratic and are focused more on the presenting problem. And it might be that there's no standardized assessment measure to do this adequately. Maybe you want to focus on attendance or homework or positive peer interactions or instances of self-injury or anything that can be in some way quantified and looked at over time with sort of a common denominator, number of times in a week. So, although standardized assessment tools often make good progress monitoring targets, they often don't. I think that's an important point. The principles of progress monitoring that we've really been talking about, that monitoring is a good idea for all youth receiving treatment. It's an information source. It's sort of the why not approach. We've had a lot of anecdotal reports from the counselors that we've worked with who thought that there was going to be kind of some disruption in their process, in their therapy process, working with kids to gather these data routinely. And that hasn't really turned out to be true for anyone. We've had a lot of people saying, I anticipated that this was going to be more of a burden or more interference than it is. But you only want to track those targets that are meaningful to the case and what's going to be really important to the treatment goals. And that's going to be different for everyone. Providing graphical feedback certainly is an essential part of this because it's going to increase understanding and remembering of how this kid's doing and help them to sort of internalize that so you can come back to it week after week. And maybe most importantly, progress monitoring allows validation and allows you to validate changes that a kid's been able to make, even if they're small changes, and allows you to tie that back into what they've done differently. Thinking about this from really an empowerment perspective and that if a kid can see that they've been able to make even a small change over time, and you can really underscore what they did to make that change, I think it has a lot of potential for some meaningful effect, especially if you're dealing with kids who don't necessarily feel like they have a lot of control of their lives, like a lot of the kids who do get seen in school settings. Selecting what to monitor, I think I've talked about much of this, but the most important thing is to sort of consider these baby steps. Remember that book from What About Bob? Baby Steps was written by, I forget the name of Richard Jenkins' character. But to think about what's going to actually be something that you can impact, and to not set kids up for failure, but to set them up for success, and really stack the deck in your favor and in their favor. This is just sort of a bit of a mini flow chart for picking what to monitor, identifying the presenting problem or treatment goal. Sometimes it happens, sometimes it doesn't. But really deciding, even if you didn't do that at the outset, what are you trying to get out of this? What's your client trying to get out of this? And picking preliminary monitoring targets, stating whether it's a negative behavior to be reduced, or a positive opposite increase. So you're going to track tardies, or you're going to track on-time attendance? Are you going to track instances of positive interaction, or are you going to track instances of negative interpersonal conflict? And kind of making that decision. I think most of us would probably say, well, I'd rather track the positive. Yeah, I would too. But thinking which of those you want to do and doing that strategically. Identifying your data source. A lot of different sources of data. Students may or may not, especially depending on developmental level, be the most accurate reporters. But they might be all you have. So I think that's just an important thing. And determining the frequency and monitoring of monitoring and feedback, which again, I think should happen weekly so that you can have the most information available and can really build into the session the expectation that this is going to be something that's going to drive a lot of the content of what you're doing. So after that, from the what to the why, that you have this information, what do you do with it? When you provide feedback, as I was talking about earlier, the most important component, at least as we've been working with the counselors surrounding, is what do you do with it and how do you drill down and figure out what's responsible for these kinds of changes, whether they're positive or negative, or even if they're flatlining and not changing at all. What could they be doing differently to try to effect some sort of change? And really do this with a mindset on kids' agency and control, and make sure that they're really buying into this. So I'm back at pretty much the points I started with. Schools provide more mental health services than anywhere else, and reduce access disparities. But it's a unique context, but a context in which a lot of evidence-based practices are untested. So in order to help school-based providers, especially school-based health center providers, in our case, integrate research evidence into the practice, we've sort of harnessed a lot of that common elements approach to think about how they can implement flexible care and still do so in a way that's going to be informed by the evidence as we kind of continue to pursue evidence-based practices in school mental health. I have a lot of collaborators, including people both at UW and in the Department of Public Health in county, and a number of different funding agencies that are helping us along in our work. And there's more information about school-based health centers up there, and listings of the school-based health centers locally. So maybe now we can jump to some questions.